And now we're going to talk about psychological treatments. So, in case you're not familiar, the DSM-5 is the book that psychologists and psychiatrists use to diagnose mental illnesses and mental disorders. If you are a doctor, then you are probably familiar with the ICD-10, which is another diagnostic manual, but we use the DSM-5. So it doesn't outline the treatment for each diagnosis, so it doesn't tell you what you would do if somebody were diagnosed, but it helps you understand what the diagnosis would be and what you might see in that diagnosis. This is based off of the medical model or the disease model, where we cluster things based off of the symptoms that we see. So if you see somebody who is having a depressed mood and socially withdrawn and feeling guilty and feeling worthless and feeling suicidal, and they've been feeling that way for, let's say, 9 months, right? Then you would look in the DSM, you would say they fit all the criteria for major depressive disorder. So, you may have heard of a little thing called psychotherapy. Now, there are different theories and techniques involved in psychotherapy, and it is beyond this class to go into all of them because there are a lot. But regardless of the modality, therapy is trying to change the mind in a positive manner, right? So, we're trying to either get rid or reduce depressive symptoms or reduce psychotic symptoms, maybe change somebody's problematic behavior. So if they are smoking meth all the time, you want to get them to smoke less meth, right? So there's no one size fits all theory or technique. Whatever modality the therapist has trained in, they'll likely use that for whatever client or patient that they're dealing with, and then they'll adjust their techniques based off of the specific needs of the client. If you're not familiar with the history of psychology, mental illness and demon possession were kind of considered the same thing for a very long time. You see somebody, talking to themselves and being secretive and saying things that don't seem to make sense. And 500, 700 years ago, you'd be like, oh, they're just possessed by a demon. Let's call the exorcist. Now, not saying that they weren't, but that could also just be schizophrenia, right? So, a lot of early psychology was just figuring out, okay, what is there a actual psychological root to this disease? And if so, can it be treated with medical or psychological interventions as opposed to just like spraying holy water on them, which sometimes works for depression. If you're ever feeling a little depressed, just have somebody sprinkle some holy water on you, cures it right up. That is not true. Uh, the an early treatment for a lot of mental illness was the frontal lobotomy. So you can see right here that the right there. They inserted a rod into the eye socket and they just twizzled the brain a little bit, which would cause people to be less active. So it would sedate them. But that's not the thing that you want to do because you're basically permanently sedating them. It's like somebody being depressed and you give them sleeping pills and then they're asleep and then you go, look, they're not saying that they're depressed anymore. Problem solved, right? So it was an early treatment for psychosis, but not a treatment that was one, really ethical, or two, something that you'd want to prescribe to people because at a certain point we learned that there were much better treatments. Our good friend Sigmund Freud developed the theory of psychoanalysis. And he worked to uncover these unconscious and subconscious processes that underpin our day to day behavior. So we understand that there are these forces that we're not always aware of that affect our day to day lives. So, some ways that we can tap into the subconscious mind are by analyzing dreams. We've talked about this before, but sometimes dreams can have meaning either if you assume that dreams have meaning on their own, right? So, if it's a subconscious trying to communicate something to the conscious mind, or just somebody's interpretation of their own dreams. So, if I have a dream, that I go to, dinner with some friends, and everyone else has a knife and fork except for me, but I panic. But I look into my pocket and then there's a knife and fork. And so my psychologist might go, well, what do you think that means? And maybe I've been really stressed recently. And I say, well, it means that, like, no matter what stressful situation happens, I'll always have with me what I need to take care of that situation. So I shouldn't be as worried about the future. And that might not be what the dream meant at all, right? That the dream might not even have had meaning, but my own self reflection on this thing that I experienced helps me learn something. So sometimes just talking about dreams can be helpful. You can also do free association or projection. We talked about projective tests and how some neutral stimuli, if you look at it, you're going to make judgments about it, and that's going to reveal what's going on with you mentally. Or just free association, right? If I told you to make up a story right now on the spot, if you talk long enough, I'm going to learn bits about how your mind thinks, right? That's a simplified version of that, but that's just to help you get an understanding of what one might see. Uh, Another really important thing is the idea of transference. In therapy, people are going to relate to you, the therapist, in a similar way that they relate to other people in their lives. So let's say I have a client who, um, every time they're speaking, uh, I might be about to say something, and then they're like, "Oh, no, 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 no! You go ahead, you go ahead. You're the therapist." And I go, "No, no, it's your time too. Like, you can also. I thought that you were done, and I misinterpreted. I can say what I was going to say later." Like, "No, no, no, no! You need to speak. You need to speak." If they're doing that with me, then they might be doing that with other people. They're transferring their relationship behaviors that exist in other realms of their life into this therapeutic relationship. So at a certain point, I might just go, I notice that whenever you're talking, even if you're not finished, you insist that I talk, even though you haven't finished talking, right? And they might say, well, yeah, well, what you have to say is more important. And I'll go, well, is it more important? And then they might think about that. They might say, well, it is because, you have all these degrees and I don't, right? And I might say, that doesn't mean that what you have to say is more important. Are there any other relationships that you have with people where you feel that what you have to say isn't as important as what they have to say? And then they might go, yeah, at like work sometimes, like, everyone else has like lots of degrees and I don't, so I feel like I really don't have anything to contribute. And then we might talk about that, right? We might really process what that means for them. And they might realize that, hey, just because I don't have a whole bunch of degrees doesn't mean that I have nothing to contribute. So people take their external relationships and then they might put it into the therapeutic session. That's called transference. So we really want to be aware of all the things that people are bringing into the session, and they're not even realizing that they're bringing it into the session. And that's what psychoanalysis is at its core, understanding those subconscious thoughts and feelings and drives and bringing them to the surface in order to provide insight to the client. Then we have humanistic therapy. Sometimes this is referred to as a humanistic existential, the big old cluster. Carl Rogers was the person who pioneered this type of thinking. So he had a very person centered approach, meaning that the client is the focus of therapy. One really important idea is the idea of unconditional positive regard, where when working with the client, it's not the therapist's job to make judgments. So let's say I'm a Buddhist and my client is Christian. And they're talking about going to church and all the things that they do. They have Wednesday night like praise meetings and all those fun things. And I'm like, well, I disagree with your religion. You're wrong. You need to convert to Buddhism. No, that is not the way to go about therapy, right? Just because my client is doing something that is different than what I would do doesn't necessarily mean that my client is wrong and I need to fix that, right? Uh, Unconditional positive regard is respecting that individual as the expert on their own life, right? So I can ask questions, I can discuss things, but my job isn't to force them to do things the way that I want them to, right? Their opinions are more valid than mine. Uh, in one of my favorite things from humanistic therapy is just the idea of active listening. Um, in general, as humans, we are very bad listeners. You've probably heard the thing where some people aren't really listening, they're just waiting for their turn to talk, which I am guilty of a lot. And active listening from the most basic is just simple reflection, right? And try this with a friend or family member sometime when they're upset about something. Just like repeat what they say, right? So let's say, my mom is really mad at my sister for something that she did. And my mom says, yeah, your sister's so disrespectful. She was very rude to me, and I'm very mad. And I might just say, yeah, my sister was disrespectful. She was very rude to you, and I can see why you're mad, right? I would be mad too. That's a little more than basic reflection, but a basic reflection would just be basically repeating what they said, right? And sometimes just having somebody acknowledge that what you said was heard is super powerful, right? We, I think I can say that probably everybody's experienced the feeling of talking to somebody but feeling like they're not listening to you, right? Or sometimes people rush into giving advice before they really hear you. It's like, well, if my sister's being rude to you, then you just need to tell her that she's being rude. It's like, well, I'm not looking for advice. I just am upset about the situation. So really, uh, going into like just being a human, right? Being a person and being there for another person. It's not my job to tell my mom like, well, like what did you do to make my sister be rude to you? Like, there are two sides to every story, right? just listening to people is super powerful. So even if you don't go on to be a therapist, you can always be a better listener. And sometimes all people need is just to feel heard, right? And just to be like, yeah, that situation really does suck. I'm sorry. Like I can imagine how frustrated you must be. Like if I were in that situation, I'd be just as frustrated, maybe even more, right? And then if they want advice, then you can give advice. But really just practicing listening to people. There is another step to this, just in case you're curious, which is when you start to combine things that they say in order to really, one, you're showing that you're hearing them, but you're also showing, you're helping them understand what they're saying, right? I'm trying to think of a good example for this. Why didn't I just prepare an example? Because I'm talking off the cuff. But back to my mom example. By the way, my mom and sister get along super well, just in case you're ever worried. So the my mom's complaining about my sister, and she's like, she's very rude. She never considers my feelings. She never blah blah blah. And then I might just at a certain point go, hey, yeah, I can see how what she's doing right now is very rude and very inconsiderate. And yeah, from what it sounds like, she never considers your feelings. That's a terrible example. And sometimes people hearing what they've said makes them double back, right? Uh, so if I'm just like, yeah, my sister's very rude and very inconsiderate, and she's never considered your feelings, that might make you go, well, no, 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 she doesn't. There are times when she's been very considerate, and it's like, okay, yeah, there have been times when she's been very considerate, but this time she wasn't considering your feelings, right? And then the person goes, okay, well, that I mean, yeah, I'm definitely upset at her, but in general, she's very loving and sweet. My sister's the best. She's real good at being loving and considerate. Not me. I'm a jerk, and then that's when you guys say, "Yeah, Professor Thompson, you are a jerk," and now you've mastered active listening. We talked about behaviorism and the behaviorist a little while ago, but just a reminder, behaviorism is a focus on just the behavior. We don't care about the psychological underpinnings of things. Literally, just there's a bad behavior. How do we get rid of it, right? So there are a few techniques that we're going to talk about, and let's start with dealing with bad habits and phobias. So let's say I'm afraid of cats. Cats are very scary to me, right? There are a couple of things that I could do in a therapeutic situation. We could do what's called flooding or systematic desensitization, right? Flooding would be going to like a one of those like cat places where you can like drink tea and hang out with cats all the time. That would be literally the most stressful situation for me. Now, what I might be equipped with are some relaxation techniques, right? So I'm with my therapist, and they're like, breathe, right? Slow down your breathing, relax, enjoy the tea. What does the tea taste like? Describe the tea to me, right? Meanwhile, there are cats, meow, 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 right? So my adrenaline is pumping, very flight or fight, sympathetic nervous response, but at the same time, I'm relaxing and bringing that bodily response down. I'm moving into the parasympathetic, right? The By relaxing in a stressful situation, we start breaking that association in our minds between that stressful situation, my fear of cats, and the actual fear response. So we're counter conditioning, right? So flooding, think of it as being tossed in the deep end of the pool and learning how to swim, right? By putting you in the most stressful situation possible, by your body just naturally getting more relaxed and more comfortable with the situation, you adjust to it. So an example of this is I used to have a pretty severe fear of heights, but I got a job in a theater. And sometimes when you work in a theater, you have to climb a lot of ladders. There was one show in particular where basically half of my body was dangling like over a railing because I was operating a spotlight. And this was before they adjusted some OSHA regulations to make sure that everything was all good. But basically, I was just dangling off of a ledge, probably 50 feet in the air. So, if I fell, I would have died, right? Doing that show after show, I just got used to it, right? So that would be an example of flooding. My body just got used to it because I just got thrown into it. So another thing that you can do is systematic desensitization, where you start small and then you build up over time, right? So maybe instead of doing the 50-foot thing, I start with simply climbing like a 10-foot ladder, right? Or I'm on like the stage, which is raised, and then I have like a 5-foot drop below me, right? Or if I fell, I'd probably barely twist my ankle. So then I move from that to the ladder. I get used to moving up and down the ladder. Then there's a staircase to a loft. I take that staircase. I'm in the light booth. And I can like see down, but I get used to that over time. Then I go up to where we have the lights, and then I go to the fly rail, and I'm in the catwalks, right? So I'm progressively exposing myself to scarier and scarier things. And what happens is at each point, I'm learning to relax and get used to it. A similar version of this back to the cat fear situation, right? I might just start with, if I'm working with a client, I might just show them a picture of a cat, an animated cat, maybe like Tom from Tom and Jerry, right? Okay, a little bit of fear, not that much. Then I show them a picture of an actual cat, then a video of a cat, right? Then I bring them into a room where there's a cat in a kennel. And then the kennel is opened, right? And the cat is on the opposite side of the room. Then we bring the cat over 5 feet away, but the cat is being controlled. Then we give the cat free roam of the room, right? It might come up to you and sniff you, it might not. Cats do what they want. But then we go up to the cat, we try petting it on the back of the head, right? That's okay. And then we go to the cat sanctuary and party with a whole bunch of cats. So you're moving up this ladder, and at each step, your response to the stressor lessens. So by the time you get to a cat sanctuary, right, you've already gotten used to being around at least one cat. So the idea of being around lots of cats isn't as intense. With OCD, we might do what's called exposure and response prevention, and that is essentially exposing somebody to the thing that is stressful, that obsession, but forcing them not to do the compulsion. So let's say somebody has a fear of contamination. I might just make them put their hands in mud. And then, by the way, don't, if you have a friend with OCD, don't just be like, oh, I learned about this in class. Let a professional do this, please. I don't need anybody suing me. So you might put their hands in mud and then force them to not wash their hands, right? So what happens is your anxiety peaks, right? Because that the response helps you feel better. So the compulsion makes you feel better, but over time your anxiety peaks and then it decreases, and then you go, oh, I did this and I didn't die, right? So by separating the obsession from the compulsion, you help reduce that feeling of I need to do this behavior to feel better. So I mentioned counter conditioning, and essentially that's what those three are doing. You're breaking that association between the two things. One other thing is cognitive behavioral therapy. So we had behavioral therapy, we had cognitive therapy. I'm not going to give you the whole history of cognitive therapy, but essentially, we were like, okay, so we can look at people's behaviors, but then we were like, oh, but also, what are the thoughts that are associated with those behaviors, right? And then we realize that those two things go together. So if you think about being depressed, right, it's not just the behavior, it's the thoughts that are related to that, or I'm worthless, nothing's ever going to get better, etc., etc. So cognitive behavioral therapy, or CBT, looks at that relationship between how we think and how we behave. Now, again, this isn't a full like lecture on CBT. You can take entire classes on just CBT. But one of the basics that I think is really helpful is to understand what are called the ABCs of cognitive behavioral therapy. So our activating events, our beliefs, and our consequences. Everybody's exposed to the same things, right? So let's just say that there was a global pandemic, right? Let's just hypothesize for a second. Some people will be okay mentally, other people will not be, right? So I have some friends who have really been making the best of their time during quarantine. I have some friends who have not been doing as well. And it's interesting because it's the same activating event. Like, some people aren't dealing with a different disease. It's not like some people are quarantined because of COVID-19 and other people are just quarantined because like a bad cold. It's the same activating event, right? But the emotional consequence is different for people. Why? Well, the difference is the belief, right? So I have some friends whose belief is bad things only happen to me. I'm so unlucky, right? And if that is your belief, then COVID-19 feels very personal, right? You believe that this is the universe's way of punishing you. And if that's your belief, then the emotional consequence is just going to be, well, why am I even trying, right? What's the point? Every time I try, something's going to happen. COVID-19, murder hornets, the universe is just trying to keep me down, right? There's some conspiracy to make my life miserable. Now, I have other friends whose belief is, you know, stuff happens, life is hard, life is always going to find things to throw at you, but it's okay. That's part of it, right? We mourn, we deal with it, we figure out a way to adjust, and that is part of life. So I have friends who have plans and, all these exciting things that were canceled, and then they went, okay, well, that really sucks that it's canceled, but what else can I do, right? I wanted to travel, but instead of traveling, I'm going to stay at home. I'm finally going to organize my home, because if I'm going to be here for a week, I might as well organize my home, right? They're able to see the bright side. So our personal beliefs can lead to positive or negative consequences. And that's one of the most important things when looking at cognitive behavioral therapy. And if you were to have a cognitive behavioral therapist work with you, they would give you homework. They would make you take a log of your thoughts. And so if I'm feeling depressed, I might say, well, none of my friends are ever there when I need them. And then I might have to write that thought down, and then I might write down three things that are that contradict that, right? And this is something that if you're feeling down, sometimes you can do, right? My friends are never there when I need them. Actually, no. 2 days ago, a friend like texted me just to check up on me because she knows that I've been stressed recently. And I actually this morning a teacher messaged me and was like, "Hey, I know that things have been really stressful. I just want to check up on you. I'm here to talk." Right. And also. A few months ago, all my friends planned a surprise birthday party for me. And I had like mentioned once that I wanted a surprise birthday like months ago, and they totally remembered and they planned something. So I guess my that like feeling of no one's ever there for me isn't completely true. And if you're able to counteract some of those really problematic beliefs, then it's going to affect you emotionally, right? Because I'm not going to go, oh, I don't have any friends, nobody cares about me. I'm going to go, I actually have some really good friends. A lot of people do care about me. So let's talk about some drugs. You might notice that there are only three general classes of drugs that I'm showing you. There are a lot. There are a lot of drugs. I wanted to just give you an overview of some of the drugs that you might see, the general classes, but this is a thing that you can take a whole class on. It would be called psychopharmacology, and you would learn about how all drugs work in the brain. We're not going to get that deep into it. We can't get that deep into it. But if you remember from talking about the biopsychological aspects of the brain, a lot of these are working in the synapse, right? This little guy right here releasing little neurotransmitters and hitting those receptor sites. Now, these just will give you a general understanding of how some of these might work. So, for example, antipsychotics, those are used to treat things like schizophrenia. There are also fast acting ones that if somebody is doing a certain drug, so for example, meth, and they're having like active hallucinations and delusions, you might use a antipsychotic to help sedate them and bring them back to normal. Uh, in some cases of bipolar 1 disorder, you might use an antipsychotic to help with manic episodes. You probably wouldn't use that for hypomanic episodes, but oftentimes you might prescribe it to reduce the severity of a manic episode. Uh, there are similar drugs that you might use for bipolar or sometimes psychosis. You might use anticonvulsants, which are sometimes used to treat seizures. You might use what are called mood stabilizers, which help balance out the extremes of bipolar disorder. On the other side, on the depressing or the depression side, you would see an antidepressant being used. So antidepressants can increase available levels of serotonin and norepinephrine, and others can also increase available amounts of dopamine and decrease acetylcholine in the brain. So depending on if you're talking about an SSRI or a SNRI or a tricyclic or an MAOI. There are different classes of antidepressants, but those are the chemicals that we tend to see are being affected. So, for example, if somebody had bipolar 1, you might prescribe them an antidepressant and an antipsychotic, or an antidepressant and a mood stabilizer, right? Or an antidepressant and an anticonvulsant. So, uh, there's no like one size fits all treatment. Psychopharmacology can oftentimes be a trial and error because certain people are going to tolerate certain side effects and be really bothered by others, right? So if I take a drug that increases my appetite and causes me to gain a little bit of weight, that might not bother me as much, right? That might, or maybe it does bother me. And I'm like, I'm gaining too much weight. I don't like this drug. I don't like the way it makes me feel. Can I switch to something else that's not going to affect my appetite? So we're constantly balancing the side effects and the potential benefits of taking the drug, right? I gained 5 pounds, but I'm no longer suicidal. That's okay, right? Then we have anti-anxiety medication, anxiolytics. These help calm the brain down by increasing the efficacy of GABA. So, aside from talking sometimes and listening all the time, what does a therapist do? A therapist is a medical professional, and as such, there are things that we have to consider. So, for example, HIPAA, right? If you've ever gone to a doctor's office, part of the paperwork that you sign is about HIPAA, which is your information being protected. So, if I'm your doctor and you tell me that you have herpes, I can just go, "Oh man, yeah, I was working with my friend, and yeah, they totally have the herp. Like they have herp so bad. That is a violation of your rights as my patient, right? In the same way, as a psychologist, I can go, oh my God, one of my clients is a huge celebrity. And let me tell you about the weird sex stuff that they're into. Gossip, 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 right? That is a violation of the trust that is held between a patient and their therapist. So we as therapists have to, and by we, I mean people who are therapists. I'm not a therapist. Fun fact. Sometimes people will be like, Professor Thompson, you're a psychologist. I'm like, no, I'm actually not. Please don't call me that. I don't want to be put in jail for fraud. It's like, your student said that you're a psychologist. I'm like, I told them not to. So I'm not a therapist, but if you were, uh, confidentiality is one of the biggest things. In the beginning of like your first session with a client, you will often tell them, "Hey, just so you know, everything between the two of us that is said in this room is held completely confidential." Now, there are some exceptions, right? If you were to tell me that uh, you were planning on harming yourself or harming someone else, then I might be required to report that. Also, in any case where there is a child who is being harmed, or a elderly person, or a dependent adult, I would also have to break confidentiality, right? So the purpose of so sometimes what might happen is maybe you're working with children, and then the kid says, "Yeah, sometimes my parents hit me, and like one time they hit me so hard that I like passed out for like 3 minutes." And that's child abuse, right? There's a difference between like spanking, which you know we're not going to get into that discussion, but sometime like I have a cat, and every so often I'll just like give him a little smack on the side because of like, you're a bad cat, right? Now there's a difference between that and then like me grabbing my cat and like throwing him across the room, and then he lands on his feet because he's a cat. He's like, that doesn't bother me, right? But the difference between like corporal punishment and child abuse, there's a very clear line, right? So if I have a child who comes to me and tells me that they're being abused, I have to report that. The reason for that breach of confidentiality is because therapists have to protect people who cannot protect themselves, right? So sometimes you hear of elderly parents who are being abused. Sometimes you hear of dependent adults that are being abused, and you have to report that as a therapist. Everything else is has to be held confidential. So let's say I was working with a client who was a like a serial killer, right? And they told me that over the past month they killed 5 people, and they haven't been caught by the police yet, and they're not planning on killing any more people. Do I have to report that to the police? Am I required to report that to the police? The answer is no. I hope that you said something. I hope I wasn't just waiting awkwardly. So, because they're not intending to do harm to somebody immediately, right? Now, if they said, I'm planning on killing again, then I have to report it. It's the rules get very interesting, but you cannot breach confidentiality unless somebody is being harmed or is about to be harmed. The other unfortunate one is in cases of domestic abuse, because the person is an adult, you cannot breach confidentiality to uh, to um, to report the spousal abuse. So that is an unfortunate one, but it's because they are an adult, right? Now, you can refer them to a like their general practitioner, and you say, "Oh, you should get that thing checked out. You have that bruise over there. Go to your doctor, get it checked out," because doctors sometimes have the ability to report those types of things. So it confidentiality and mandated reporting can be a little bit of a complicated issue, but essentially it's the purpose of mandated reporting is to protect people who cannot protect themselves, right? So in some cases you might want to put somebody in a psychological hold, a 5150. So for example, if somebody is like, I'm super suicidal. Like, I'm like, thank you for being my therapist, but like, you won't see me next week. And like, you say, hey, let's talk about this, and you try to work out a plan. And then, like, no, I just can't see myself going any longer. In that case, you might want to put them under an involuntary hold. You call the police, they take them to a facility, and they hold them for 72 hours in order to bring them, like, help them get back to normal so that they're no longer a danger to themselves. Also, sometimes, as mentioned before, a person might be doing harm to someone else, or somebody's symptoms might be, or they might be intending to do harm to someone else, or sometimes somebody's symptoms might be so severe that they are disabled. So let's say somebody was actively hallucinating, and you were like, I don't think this person should be like on the road. I don't think this person is safe to go back to work. This person is a danger to themselves and to others. That grave disability would be reason for a psychological hold. So ethics are very important in the field of psychology, as you might assume. They are put together by the American Psychological Association, the APA. One of the biggest ethical breaches is do not have sex with your clients. The reason for that, just in case you are curious and you were like, why wouldn't you want to? Uh, because you have power over them, right? And any breach of that would be an abuse of power, because there is a power dynamic, right? This person is paying you, and also they have all this personal information about you. So they so you're saying, like, so it's an uneven or sorry, the person is paying you and they've given you all this personal information about themselves. So you're all the way up here. My hand is up here. You can't see it, but just imagine it up here. And they're all the way down here. You also can't see my other hand, but it's down here. So that creates a power dynamic, right? In a normal relationship, it should be about 50-50. In the therapeutic relationship, it's like 90-10. And if you're manipulating that in order to have sex with your client, that is an abuse of power. So definitely a no-no, right? Uh, so boundaries are a very important thing in therapy. Now the that on the other end of that, some people get really crazy and they're like, well, never like touch a client ever. But it's like if like a client is crying and like it feels natural to like put your hand on their shoulder, or like if they want like a hug after a session because it's been emotionally draining. They talked about the death of their father and they've never talked to it about anybody, and like it feels natural and you're comfortable hugging them. Like you can be a human being, right? But don't be the human being who takes that and is like, hey, what are you doing after this, right? Don't be that person. There is a like it becomes almost a joke in grad school because you hear it said so much, because there are people who unfortunately take advantage of their powers sometimes. So you need to be very careful with that. The other issue is dual relationships. So you have to be careful of having a relationship, even if it's a non romantic one, with your client outside of the session. So for example, sometimes therapists at a university will also teach some classes at the university. So it would make sense if you're a psychologist at a university and they need people to teach like theories of psychotherapy, you might be qualified to do that, right? So sometimes you might teach and also do therapy at a university. Now, if one of your clients is also your student, that becomes an issue, because you're privy to things that are going on in their life, right? And it's very hard to be objective. Even no matter how hard we try to be objective, we always have biases, right? So you want to be careful to not go, oh man, well, I know that they're feeling really depressed and anxious right now, so I shouldn't grade them that hard. Or they turned in an assignment late. Let me reach out to them and see if they're okay, right? If you wouldn't do it for other students, you don't want to do it for them. So dual relationships in therapy can be very problematic. In general, you want to avoid them. In some cases, you can't avoid them, but in cases where you can't avoid them, so for example, you that student needs that class to graduate. You might say, okay, for the rest of the semester, I'm going to refer you to one of my colleagues, or let's have a talk in our session about how to. The fact that I cannot treat you differently than any other student. Well, there are ways to work around dual relationships, but it's a very important thing to be aware of. So, like everything, there are issues involved in therapy. One thing is court reporting. Sometimes you are subpoenaed and you have to testify in court on behalf of a client, or you might just be a expert witness and you might have to meet with somebody and diagnose them, and see if maybe the insanity defense is applicable in that situation. Just so you know, the insanity defense is not a formal diagnosis. It is a judgment of somebody's like culpability. So It's not saying like I'm diagnosing this person with schizophrenia. It's saying this person isn't aware enough of themselves or their surroundings or reality to be able to be at fault for the thing that they did, right? So that is a thing. Sometimes you are called to be an expert, and it can get complicated. Sometimes it's very hard to judge somebody based off of just a few interactions about whether or not they are legally insane. Uh, Another issue is just the idea of how do we know if people are uh, faking it, or to put it bluntly, like faking it or not, right? The Rosenhan experiment, which some of you might have read about, uh, basically what was done was people pretended to have psychiatric illness, and they were institutionalized, and they did not show any actual psychological illness, but nonetheless, they were institutionalized. This is problematic, right? If I go to a hospital and I say my leg is broken, and but my leg is not broken, but they put me in a cast, reset my bone, and I'm in a hospital bed for a week, right? They should know that I actually was had a broken leg. There should be some way of discovering that, right? But the fact that we can be tricked is part of the issue of psychology as a field. Because it's not always something tangible that we're looking at, sometimes if we expect to see something, then we see it, right? If somebody comes to a clinic and says, hey, I'm hearing voices, or I'm hearing sounds or something like that, well, I've seen 100 people in the past year who came in saying something similar. This person must be doing the same thing. And so we really need to be aware of our biases when it comes to diagnosis. So finally, we have to look at the idea of like, does psychotherapy do anything for people? Is it actually effective? So Ising did a study, and in that study, he found that there wasn't much evidence of recovery within that specific study of the patients that were being measured. Thomas Saz also point out the fact that biological or chemical tests, like there's nothing that you can look at in the body that will verify that something is an actual disease. Now, these were years ago before we could do brain mapping, and we could measure like things like serotonin turnover and blah 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 blah. So now we know that there actually are biological markers, but it's not as apparent, right? So we rely a lot on self-reporting, which is difficult, because some people might overstate their symptoms, some people might understate their symptoms. So it's very hard to know what you're actually seeing in a situation, right? But still, we do know that some people benefit from psychology. Some people benefit from psychotherapy, and it's going to depend on the therapist as well as the techniques that are being used. There are some things that are very easy to measure, right? So if somebody is smoking and after 10 weeks of therapy they stop smoking, then we've created some positive change, right? Now, if somebody is depressed and after 10 weeks of therapy, they are still depressed, but they have more insight, they are more aware of their own feelings, they're more in touch with themselves. They've started making positive changes that in the long run will affect their depression. Sometimes it's very hard to measure those specific things. So sometimes what ends up happening is that we're measuring the wrong thing, right? So when looking at whether or not psychotherapy is useful, of course it is, right? Sometimes we might target the wrong things in our measurements or in the actual therapeutic sessions. Maybe we don't need to spend 10 weeks talking about somebody's relationship with their parents, right? Maybe we can just get them to stop doing meth. Maybe that's the thing that we should focus on. But in general, talking about our issues, gaining insight into ourselves, understanding things, and working towards positive change is a good thing. So, hopefully, in this class, you learn some things about yourself. Hopefully, you gain some insight into the things that make you. Hopefully, you are a little bit of a better person as a result of it. Thank you for being a part of this class. That's it. We did it. You still have a final, but we did it. Hey, celebrate good times. Come on. Woohoo.